I'm
I first met
trying.
Karen. No worries. I first met Karen at a brain injury advisory council and was able to chat about, children, youth, and the cross section with traumatic brain injury and what that really looks like here in North Carolina. Karen Rice is an associate professor in the Duke University School of Nursing, School of Medicine, Department of Pediatrics, and the Duke Institute for Brain Sciences. Her expertise includes pediatric critical care and brain injury. She is a fellow of the American College of Critical Care Medicine, American Academy of Nursing, and the National Institutes of Health Summer Genetics Institute. She is a co-editor of the textbook Pediatric Acute Care, a guide for interprofessional practice. Her commitment to the care of ill and injured children and their families has led Dr. Rice to focus on her research in the area of trauma and head injury. With a collaborative research team approach and funding by National Institutes of Health, Robert Wood Johnson Foundation, Duke University Center for Applied Genomics, Dr. Rice examines the relationship of symptoms and potential biologic markers that impact outcomes in children with mild traumatic brain injury, concussion. Her published research findings have been presented internationally, and in addition to her research, she also chairs the North Carolina Brain Injury Advisory Council's Child and Youth Committee, which supports policies and regulations to improve the lives of children and youth with traumatic brain injury. So without further ado, I'm going to turn it over to Karen, and I'm looking forward to learning what you have to share.
Well, thank you so much, and thank you everyone for joining this webinar today. We know these are kind of difficult times for many of us, and we're being socially distanced, so a webinar seems like a great way to spend at least an hour or a bit more than an hour with some new content, or maybe some content you're already familiar with, and I'm very pleased to be here to speak with you. So I know Lauren told you a little bit about what I concentrate on, which is really looking at children and youth who've experienced a head injury. And I work primarily as a researcher, but I am faculty, so I teach students anywhere from high school through to graduate school, through students who are getting their PhD. But more importantly, you should know that I'm a nurse, and I'm a nurse practitioner. And so this is very dear to me, because I have, cared for children as a nurse for well over 25 years. And as a nurse practitioner, I've seen a number of children who have had head injuries. I've always been very puzzled by the fact that some children do so well after they've had a head injury and others have not. And that kind of led me on the quest of my research, which is looking at better understanding what's happening after you've had a head injury, both from a physiologic, meaning from a biologic perspective, but also from a symptom perspective. And so I'd like to start by thanking you, but also thanking the Brain Injury Association of North Carolina for this two-part invitation. So as chair of the North Carolina Governor's Brain Injury Advisory Council Children and Youth Committee, that's a real mouthful, I have the pleasure of working with a whole host of individuals who are passionate around improving the health, education, and well-being of children and youth who've experienced a head injury. I know that, this is Brain Injury Awareness Month, and so it's important that those that have experienced a head injury, families and partners and allies who are, certainly living with individuals or caring for individuals who've experienced a head injury, are aware that we are very passionate about this, and that the month of March is where we try to make sure we highlight it, so for those that are unaware, they become aware. I also want to thank Lauren for, inviting us to do this as a two-part series. So what you'll get today is really more foundational and providing you with content that talks about what is a concussion, what do we know about concussion, how do we treat a concussion, and what does the science, what's the science saying about concussion? But importantly, the part two with Lynn Maker is going to talk to you more about how are we implementing these type of resources for children within our school systems in North Carolina. So without further ado, I will tell you I have a number of collaborators that I work with both at Duke, at UNC. I work with individuals at Stanford and Pittsburgh, the Brain Trauma Foundation. And so I've pretty much made this the focus of both my career, but also I think where all of my energies go. So I have no disclosures, and I think that's important to share with you. And then the objectives for today. So we're going to talk about what is concussion. We're going to look at the incidence and some of the most common reasons for concussions in children, both in the, across the U.S. and in North Carolina. And then we're going to talk a little bit about the symptoms that are associated with concussion, and then talk more about what do those treatments look like, and what are we doing as far as science and research in this area to promote recovery. So many of you know that concussion is a traumatic brain injury. I think that often in history we've thought of concussion as, well, you just rang your bell, or I've heard people say that, or you just got a knock on the head and you'll be fine. And I think that it takes somewhat out of context that this truly is an actual injury to the brain. There are actual biologic changes that happen in the brain after the concussion. So concussion is really defined now as a mild traumatic brain injury. It acknowledges the fact that it truly is a mechanism of injury to the brain, and it fits within the region of severity of mild. And we'll talk a little bit more about that as we go through the webinar. So the traditional definition, and you'll see this probably almost anywhere where people try to define concussion, is it's a bump, blow, or jolt to the head, or a hit to the body that causes the head and brain to move rapidly back and forth, or actually in rotation as well, which you often will see a boxer get, when they're hit from the side. The sudden movement can cause the brain to bounce around or twist in the skull. It creates chemical changes within the brain and sometimes stretches and damages the cells within the brain. So what does that really look like? And I think that the majority of literature that talks about the incidence of concussion really focuses on the fact that over 75% of traumatic brain injuries are considered concussions. So the majority of brain injuries that we see nowadays are actually concussions, so fitting within the category of mild traumatic brain injury. It's important to note for children and youth that 1 in 5 children will suffer a concussion before the age of 16. That's pretty impressive when you think about how little we actually know about concussion and how to treat it, but the high incidence of it within children's age group. And that we see about about 1 million annual visits, and this is emergency department room visits. This doesn't really even account for the doctors, offices, the urgent care visits, but these are the reported, trauma-related visits that we can account for. And we estimate the cost to be $1 billion spent in healthcare, but it's probably much more than $1 billion. Oops. All right. Um, so, as a schematic to give you an idea globally around why, what causes, traumatic brain injuries. And this is using the whole schema of both mild, moderate, and severe. The majority of injuries are typically from falls or some type of struck by something or hit by something, or being involved in a motor vehicle collision. But I think what's important here is that in children, falls are typically between the age of 0 and 4. The highest, is the highest mechanism of an injury for a traumatic brain injury in a child from 0 to 4 years of age. Whereas in adolescence, so that 0 to 24, so that youth age group, it's typically motor vehicle collisions. So this is kind of reflecting back on what I said earlier, is that you can see here that, it's estimated that 70 to 90%, the Centers for Disease Control report for emergency department room visits for mild TBI. And then a study that was conducted looked to see that about 85% of them, again, validated that seeking emergency medical care, 85% of these kids had a mild TBI, and most commonly, these mild TBIs are concussion. So what does that look like for us in the state of North Carolina? Well, it's important to note that in the state of North Carolina, and these are old statistics, but the most recent ones that I could access, we had a little over 78,000, almost 79,000 individuals who sustained a TBI. And that, of course, now is mild, moderate, and severe. But I think it's important to note that almost 70,000 of those were treated and released from emergency departments, which tends to lean to it being a mild TBI, because you wouldn't be released from an emergency room department if you were experiencing any moderate or severe traumatic brain injury symptoms or signs of injury. And so if you look at the right, you can see the number of deaths from traumatic brain injury, you can see the number of emergency room visits, and then you can see also the number of hospitalizations and the reasons behind those. And again, you can see that the unintentional falls, which is that shade, that kind of grayish blue shade, is 48%. So the majority of individuals receive a traumatic brain injury from a fall. And I like this slide because it actually broke it down by age for North Carolina. And again, this is reflecting back on 2015 data, but we do know that we're having we're capturing more mild TBIs now because people are more aware that they're actually an injury and they need to be reported. And so if you look at this graph, you can see that for emergency room or emergency department visits, 23% of those, so that very bottom scale, are 0 to 14 years of age. And then if you look at the opposite end of that scale, 24% are 65 and older. And those really are our most captive group of individuals who are experiencing concussions or mild traumatic brain injuries. So in North Carolina, if you think of this group right here, 23%, 0 to 14 years of age, and you think of the number of kids we have in North Carolina, which right now is a little more than 1.5 million school-age children, you can see that there's a high incidence of concussion. And this has led us to be somewhat more proactive around what do we do for children in North Carolina who are at high risk for experiencing concussion. So if you think of my earlier data that I gave you, 1 in 5 before the age of 16, and you look at the number of kids here, how are we better making individuals aware that traumatic brain injury, meaning a concussion, is a mild traumatic brain injury, and also that these are injuries that need to be assessed by a healthcare provider and also need to have some form of evaluation, follow-up, and treatment. So let's talk just very briefly about concussion in the brain. So I think it's important to note that children's brains don't reach adult weight, which is about 3 pounds, that's how much the brain weighs, until about the age of 12. But more importantly, the brain's frontal lobe, so that's along your forehead, that lobe does not reach full cognitive maturity until the mid-20s. Well, why is that important? Well, it's important because that lobe houses all the executive function skills, such as judgment, problem solving, having, mental flexibility. It's also the lobe that is very susceptible or very vulnerable to injury. And so damage anywhere along that developmental continuum in a child. So think of your, your frontal lobe isn't fully developed until your mid-20s, but you're having, you're having concussions at the age of, 10, 12, 15. You're not, your continuum is now, your brain your brain developmental continuum is now being affected, and that impacts your executive skill functioning. And so we need to be very cognizant about the fact that there are sequelae to injuring the brain. So what are some special considerations that we want to think about when we're looking at concussion? Well, there are mechanisms of injuries, and I'm going to go through each of these individually. The biological impact, and then the pre-existing conditions or increased risks, and then psychological challenges. So mechanisms of injury in children and youth, pretty much resemble those of adults, except that we see, children tend to be bigger risk takers. So, they're going to try for that monkey bar, or they're going to try to speed up, how fast they can go down a hill on their bike or their scooter. We know that any kind of wheeled toy, so if you think of, scooters, skateboards, anything that has a wheel on it that can roll, kids will put themselves on it and are at risk for falling and hitting their head. Of course, youth sports is very, particularly contact sports such as soccer, hockey, football, any kind of other lacrosse, anything where there's actually impact between equipment or other players, you're at risk, of course, for concussion. And then you can have concussions from motor vehicles, even as a belted passenger. The biological impact is the other piece that we take into consideration. And so you can see here these two figures, one with the rotational injury and one with the linear injury. And these are described on the slides, where when you see the rotational injury, there's these shear forces that are created throughout the brain, and they damage the brain tissue. Then there are the linear forces, which is more of this acceleration, deceleration type of forces, this forth and back, where the brain is knocking at the front of the skull, and then it also hits the back of the skull. And here we know that we have axonal tearing and stretching, and the axons are part of your nervous system. So we know that once these start to shear and stretch, that it leads to metabolic or cellular changes within the actual brain itself. And we also understand that there are then those cellular components that either lead to symptoms or signs that we see in someone who's experienced a head injury. Particularly in this case, because we're talking about concussion, you'll start seeing signs and symptoms of that injury. The other thing we're very cognizant about, and we're getting much better research around these areas, are there pre-existing conditions or increased risks that put you at risk for either having more dramatic symptoms, longer symptoms, or the fact that you may actually be at risk for poor recovery. And so one of the things that we know is that if you've had a loss of consciousness after hitting your head for more than a minute, you tend to have worse symptoms or longer symptoms over time. We also know that if there's a headache history or a migraine history, either in the child or youth, or even in a family member, a direct family member like a mother or a father, that these individuals may be predisposed to having more headache symptoms or migraine symptoms. Also, that those symptoms may last longer. We know psychiatric history is the same. Anxiety, depression, sleep disorder, and other type of psychological disorders may also lead to those type of symptoms being more prevalent in the individual once they've sustained a concussion. And the same is true for developmental histories such as learning disabilities, ADHD, and developmental disorders. Having a previous concussion, I think this is a really important piece in that if you've had a previous concussion, you're 3 to 6 times more likely to have a second concussion. And what we found is that second concussion can be a result of even less force or less impact. So it could be a much less severe concussion, but it could also last a whole lot longer, and the symptoms can last a whole lot longer, which is why we're so vigilant now about how many concussions has a child experienced and we're trying to prevent second concussions and thereafter. We also know biologically that females may being a female may also put you at risk, and that the severity of your injury may be more severe. But we're not completely clear about why that is yet. There's some very small studies that are starting to point in this direction. And we also know that younger age means that you're going to have a longer recovery period. And we simply know that earlier from the slide when we talked about brain development. And so, the earlier your brain is impacted, the more that developmental continuum is impacted, and thereby you also have a higher risk of having what we would consider a protracted recovery or a longer time to recover. And you may actually even miss some of your basic milestones. So, there are psychological challenges, and I think one of the things that you'll hear more often is that they look fine. Well, you're right. Unlike a child who's broken their leg and has a cast, who everybody can see has sustained an injury, children with concussion, unless there's something very physically obvious around, like a big knot on the head or a shiner or something that gives people a clue that they might have struck their head, they usually show no symptoms of having had a head injury, or no signs of having had an head injury. Uh, they may exhibit symptoms, but they won't show any obvious signs. So people just assume that they're fine. We know that symptoms are very variable and that they're very individual. So how I may experience symptoms after a concussion look very different than how you may experience them. We know that information varies among healthcare providers. How much information is provided to each individual, it may differ between clinics and health systems. Um, we know that oftentimes there's poor communication with family and follow-up, which also then affects how recovery takes place for children and youth. And we've already kind of talked a little bit about the pre-injury factors. So I like to say that no one plan fits all. So like if we're thinking about how are we going to help children who have had a concussion, that if you've seen one concussion, you've only seen one concussion, because everyone is very individual, and we need to be thoughtful around what works for one person may not work for another. So let's talk more specifically around symptoms. So once let's say you're that individual who's had now contact with either the ground because you've fallen and you've struck your head, or you've hit another player playing a sport. The most common symptoms that are first reported that kind of put you in this bucket of concussion are: you might have had a loss of consciousness, you might experience amnesia to the event, and you might have some mental status changes. And then we'll talk a little bit about the Glasgow Coma Scale, where you have a score of 13 to 15. Now, I just want I just want to point out that you could have loss of consciousness and amnesia and mental status changes, or you could just have one of these. But typically, the rating for a concussion as a mild traumatic brain injury will always be a GCS of 13 to 15. So what is a GCS and why do we use it? Well, it's a very crude scale that we, have used for many, many years. It assesses the level of neurologic impairment, and it's most commonly used by emergency medical services, the emergency department, or urgent cares. And what it does is it assesses the individual's, response to eye opening, their motor response, and their verbal response. And typically, individuals that have had some mental status changes may actually reflect one of these categories, which are then given a point, and that point total is added up. And so for a mild traumatic brain injury, they typically will have a point score of 13 to 15. So when we think about the injury, we think about loss of consciousness. So I have here that there's been information around, have you lost consciousness less than 20 minutes? Well, 20 minutes is a really long time to be unconscious, and you'd have to worry they actually had a pretty significant head injury. Also, this post-traumatic amnesia, it may be less than 24 hours. You may not, they may be stunned at the beginning, but then as the day is going on, they may not be able to account the events of what happened. So when I put this in red because I think it's really important that even though as part of our criteria we look at loss of consciousness, recent study, or not so recent, but reported study, has shown that only 81 to 92% of kids have no loss of consciousness. So let me reword that. So kids who are in sports or some type of other activity where they've had a concussion, the majority of them, so anywhere between 8 to 19% only suffer some loss of consciousness. And I will tell you, just based on experience, that loss of consciousness is typically very short, less than a minute, a couple of minutes at the most. So this greater than 20 minutes to look at brain severity, if you're see somebody experiencing that, that's something that should be a real red flag, that they probably have greater than a concussion. So what do bystanders report as far as signs and symptoms? Well, it's important as a bystander. What you'll often hear is you'll say, they can't remember what happened before or after they were hit or they fell. They, appear dazed or stunned, or they're just acting weird, or they've been, they just don't seem themselves. They often will not be able to follow instructions, or they seemed confused around what you're asking them to do. Um, they appear more clumsy. They may answer questions more slowly, like they can't process what's being asked of them. Again, the very brief loss of consciousness, and then they may show some mood or behavior or personality changes. And often what I've heard people say is they seem more irritable, or they're very quiet. Um, they're usually a really happy, active kid, and here they've just become really quiet. And then symptoms that the children and youth often report are they feel like they have a headache, or they feel like, if they can't describe what a headache is, that they have pressure in the head. They sometimes will experience nausea or vomiting. This typically may be shortly after or within the first, 8 hours of the event, but it typically isn't prolonged. They may complain of some balance problems or dizziness, or say that they've got double or blurry vision, or things look fuzzy to them. They're bothered by bright light or loud noises. They don't feel like they're on point. They feel sluggish or hazy, foggy or groggy. They may be confused or have difficulty remembering things or concentrating on things. And globally, they'll just tell you they just don't feel right. Things don't feel like they normally feel. And so one of the instruments, and you can find this on the CDC Heads Up site, is this acute concussion evaluation. And this is, this one is specific for physician and clinician offices, but they also have them for school nurses and for others to use as well. And essentially what it is it's an intake screen to get history about the event and the characteristics around it. And then there's a really nice symptom checklist where you can total up a number of symptoms. And then there are, of course, risk factors that would give you a heads up that somebody may have risk for a longer recovery time point, and then also red flags. And so this schematic just kind of puts some of these symptoms into an easy translatable, quick to look at. And that is that, for emotional and behavioral symptoms, they may complain of nervousness or anxiousness or irritability, frustration, anger, or sadness, headaches, nausea, dizziness, sensitivity, which we talked about, to light and noise, the fogginess, the feeling slowed down or difficulty concentrating, and then having difficulties with sleep disturbance. But importantly, we don't want to forget that sometimes the symptoms may be very subtle at the beginning, and oftentimes families don't recognize that there's actually been an impact if they actually are not actually seeing the impact happen. And oftentimes the impacts happen and people don't even know that there's an impact. But over several days, the child is not acting right. That's when they start getting this idea that they maybe need to be evaluated for a concussion. But this slide here talks more important about the red flags, which I showed to you on the, earlier acute concussion evaluation form, this red flag section. So these red flags are when you need to escalate to emergency department or urgent care evaluation, or have someone like an emergency service individual come to your home to evaluate and transport the patient. And this is when there are pupil changes, when you suddenly cannot arouse the individual, when the headaches is progressively getting worse and worse, when there are true changes in their motor function, when vomiting and nausea just does not stop. Individuals don't recognize people or places that are familiar to them. They have increased agitation or confusion or restlessness. Their behavior becomes more unusual and they have a slurred speech, or you actually witness a seizure, or they have loss of consciousness, even if it's brief. So it's been over that 24-hour period, and now you're even seeing a return of loss of consciousness. The likelihood is that this individual has a much more severe head injury than a concussion and should have immediate medical attention. So let's walk through concussion treatments and what we know. So these concussion subtypes are part of a national group of experts who, for the CDC, created concussion guidelines, and these can be found in the Part 2 section of these guidelines. And so this expert group, led by Dr. Lumbaugh Brown, really looked at the most prevalent groupings of symptoms to subtype individuals with concussion into 5 groups, so 5 subtypes. And they found that when they identified these subtypes, they were better able to think about treatment plans that were appropriate for these different subtypes. So it's important here, you can see to the right of your screen the prevalence of these type of subtypes. So headaches and migraines are the most prevalent subtype, followed vestibular. And vestibular is really this kind of inner ear, this motion imbalance. And you'll see that about almost 20% of individuals complain of that and actually have on testing some balance issue, which is likely attributed to some process within the inner ear. And that's a brain-related process, not necessarily just an ear process. There's mood and anxiety changes. Then ocular motor is that seeing and balancing and being able to, when you're climbing a step, you see the step and your depth perception is accurate. So that ocular motor coordination, being able to track your eyes across the room without feeling nauseated or having, difficulty focusing and following. And then cervical strain, and this is often, if you remember those 2 pictures of the acceleration, deceleration, that linear force, or the rotation where the head is being snapped to the side, you can have strain within the cervical, which also then leads to changes within your cognitive and balance functions. So post-concussive treatments, they still start with brain rest. And, much like anything else, when you've injured it, it needs a time for healing. And so, most treatments start with this type of process, as you can see is the upper part of my screen, which is brain rest, restful home activity. Then there's a return to school activity, maybe for the partial day, then to full day, and then full recovery. And much of this is based on what the individual looks like, what symptoms are they reporting, and how are those symptoms responding to activity. So when they're in a state of rest, are those symptoms going away? And then when they're in a state of activity, are those symptoms returning? Or are they slowly also dissipating? So treatments are tailored to the subtypes and often the symptoms. Symptoms flare when the brain is asked to do more than it can tolerate. So that's that whole measurement of how much can you do before you're actually creating more harm than good. Limiting your physical, emotional, and cognitive activities to a level that's tolerable and doesn't exacerbate or cause reemergence of the symptoms. And so, for example, one of the challenges that we see is that, brain rest is probably somewhat difficult for most individuals who are in environments, if you take a child in school, where it's noisy and it's active, and they're expected to concentrate, and they're expected to sit for a certain number of hours within a classroom and be attentive and be able to provide some measure of their understanding, whether that's test taking or whether it's completing an assignment or participating in class. And so you can see that that does require a certain amount of coordination. It takes a certain amount of eye coordination, balance coordination, motor coordination, and then brain activity, such as the ability to cognitively think through things. And then we think also about age-specific physical and cognitive rest issues. So it's much harder to ask a 7-year-old to sit still and just rest their brain than it is a 17-year-old, right? And so thinking about what are realistic, rest issues that you can work with the patient to help them feel better, or the family member or the child themselves. And then thinking also about symptom resolution, like how long should it take for these symptoms to go away? And are we following a good treatment plan that's allowing those symptoms to go away over time because the brain itself is healing? So recovery from a concussion really is a whole gamut of things. And sometimes, for headaches, for example, you may have someone take a medication for that. Other than that, there aren't a whole lot of medications we can take to treat a concussion. Also taking mental breaks from activities that require concentration and focus. So your eyes, your ears, your senses, as well as your ability to think things through. This is really tough because many children are very device driven, so they're very accustomed to interfacing with some type of digital technology that requires screen. Screens are lit, they're fast moving, they may be interactive, and how does that impact their ability to rest their brain? And so those are the things that we take into consideration when we're planning treatment plans for children with concussion. The other thing that we want to take into consideration, and I've already talked about this, the cognitive and rest issues, but more important, and I see that I've got a couple of these that are redundant from the prior slide, but thinking about extending symptom-free periods before starting return to play protocols. So think about, not all play is recreational sports or sports that are organized, but rather recreational play may simply be a child playing with, a group of their friends, or running around the neighborhood, or, interacting in a way that creates some kind of physical and cognitive exertion. And then thinking too around what it takes for a child to return to play, but also what does it take for a child to return to learn? And we'll talk a little bit about that. I think one of the most important things that I'd like you to take away from this slide is no child should return to play, and that's any kind of play, particularly wheeled toys or contact type of play, until they're cleared by a healthcare provider. And that's simply to go back to the risk of sustaining a second concussion, and thinking about the fact that second concussions, put you at higher risk for more injury and protracted symptoms, but also there is something called second impact syndrome. That is where someone has sustained a concussion, and shortly thereafter they sustain a second concussion and they have a major brain injury failure. And so I, several years ago, was asked to evaluate a court case of a child who was playing a youth sport, sustained a concussion, was evaluated immediately by a healthcare provider who put the child out of play and put him on a treatment plan for concussion. It was all very appropriate. The child went to school the following day, and was on the monkey bars and fell and hit his head again, and was then, of course, evaluated and transported to the the hospital and died within 48 hours from a massive secondary injury. And that's a rare thing, but it's a real thing. And so our evaluation of children who have had a concussion, by no means should they be able to return to play after that evaluation until appropriately cleared. It also means that we need to use appropriate symptom checklists. So what are symptoms and how do we measure them and how do we follow them over time to know that we're actually, the treatments that we're using are actually improving the health of the children and their concussion recovery. And also including both parents, patients, school nurses, and the school team personnel, which includes both if they're in a recreational sport or an organized sport, the coach, the athletic trainer, and anyone else who's involved in managing students who play sports. But then again, teachers, psychologists, counselors, so that everybody is on the same page, making sure that, this kind of coordinated effort leads to a quicker recovery. And then also appropriate neuropsychological testing before the symptoms resolve to make sure that we're planning the right school management. And there's some really nice assessments that you can find online. And I've just put one here as an example. And this is a sports concussion for an assessment that you can just use the website and go in and learn more about. And then the important piece around athletes, because we know many of them are at high risk when they're involved in a contact sport, that we manage them the same regardless of their level of participation. I think this is really important. There is no difference between being in a recreational sport and falling and hitting your head and having a concussion, or being struck by another player. Whether you're in an elite sport or a non-elite sport, a concussion is a concussion. And so we need to make sure that we're managing and providing treatments regardless of the level. And that's also true that resources are available regardless of your elite or non-elite sports status, and that there's really a coordinated management effort in resources. And so those have been the challenges that we've experienced around treatment recommendations. So I want to just highlight this risks associated with premature return to contact play or even continuing to play in a setting of a concussion. We know the symptoms worsen. We know the injury is worsened. We know they have a prolonged recovery. We know they're certainly at high risk for repeat concussions. And we know that there's an increased risk for musculoskeletal injury, with a focus on the lower musculoskeletal extremity, so your legs and hips and knees and ankle joints. There's a really great website that provides a lot of good information, both for parents, children, healthcare providers, school providers. The CDC Pediatric Traumatic Brain Injury Guidelines have great information, as does the CDC Heads Up. They've got some excellent resources. So in North Carolina, what are we doing to protect student athletes? Well, we have the Gefeller-Waller Concussion Act, which was drafted and implemented to protect the safety of student athletes, and it was signed into law in 2011. And why is this important? Well, the act was really designed to focus in on student athletes. And we realized that, and I'm going to go to the next slide, that there was a whole subgroup of kids that weren't addressed. I'm going to talk about them next. But the Gefeller-Waller Act, what it did was it really covered these major areas, looking at the realm of school-related sports, looking at who should be involved in the act itself, so coaches, school nurses, volunteers, student athletes, and parents, making sure that there was an emergency plan and protocols for athletes who experience a concussion, and then return to play procedures for student athletes. But what this act didn't address were students who sustain concussions anywhere in or outside of school. So those students who fall off the monkey bars, or those students who are just playing tag and fall and hit their head. It also didn't account for materials for all educators in the state of North Carolina in the public school system. It didn't account for removal of play or physical activities for all students who sustain a concussion. It was only for those who were student athletes. And there were no protocols that were specific to return to educational environments for all students who sustained a concussion. And so what happened then was there was a group of individuals coming out of the North Carolina, the committee that I actually chair, but prior to my arrival, this gap was recognized that we were really failing a whole group of students in North Carolina that were at risk for concussion. And so what happened was a group of school nurses, school psychologists, counselors, neuropsychologists, Department of Public Instruction staff for the Healthy School sections of Curriculum and Instructional Division, the DPI legal team, and Exceptional Children's team all came together along with members of the Committee for Children and Youth to look at appropriate recommendations. And what you saw and what you see on your screen here really are these policy recommendations that went into effect in October of 2015 or here it says September of 2015, but essentially went into effect to provide services and better materials and education for all students in the North Carolina education system. And so this policy was linked to the State Board of Education strategic plan, and what the goals were that every student is healthy, safe, and responsible, and that they promote healthy and active lifestyles for students. And so that was the general approach. And so what's happened since this policy went into place? Well, we did a review of the actual implementation of the policy, and what that required was annually the school, North Carolina school nurses literally house a data set or a database where they account for any reported concussion. So you can imagine there's some that are being missed because not every concussion is reported. And what you'll see here is that just even in the 2 years, 2015-16 and 2016-17, just the amount of reporting that was suddenly being captured because of the awareness campaign around concussion, the language as well as the training of individuals around concussion within the North Carolina system and the school policy, you can see that exponentially there was more collection of data, and that's simply because it was being more recognized. So as a byproduct of that, we also decided as a committee we needed to provide individuals with resources. And what we did is we developed resources. This is now the second version. So this is our second edition of both English and Spanish brochures that provide information for families on what is a concussion, understanding its impact, and then what is it that they need to be looking out for and how do they communicate with both healthcare providers as well as school educators around concussion. And I've left you both the websites, but also handouts that you can certainly review at your leisure. We, in our very first, before they even went online, we had a printing of 100,000 brochures. And we printed those 2018, 2019, and our second printing for the second edition just started. We have those now available because we went through 1,000 brochures in under a year. So I want to move on and talk about why is all of this so important. And I think it's because concussion really is an invisible injury. There's a huge emotional and social impact after the injury and during the recovery period. There's very high potential for students to be isolated from their peers, from the activities that they're most accustomed to being part of, as well as the academic stressors when you're falling behind in school. And we really don't know the long-term effects of concussion, both from a biological perspective as well as from just a social economic perspective and from a wellness and quality life perspective. So I want to briefly talk about some novel research strategies that are ongoing right now, and I'm going to run through these individually so they'll each be on their own slide. And it'll talk to you a little bit about what how much of a gap there still is within our understanding of concussion and what we can do to work to prevent it. So these are the topics that I'm going to just quickly go through, and then I'm going to open it up for questions. So we know that one of the biggest byproducts of having a concussion is this prolonged post-concussive symptoms. And so what's important is that they've demonstrated in school athletes that concussion, about 10% of them will develop these ongoing symptoms. And the estimates are kind of all over the board between age groups and populations, anywhere from 5 to 30%. And so what we know in the literature right now is that between the age of 5 to 18, the most recent studies are saying there's about a 30% chance of individuals still having concussion symptoms at 3 months after the injury. Uh, of those symptoms, they may go on to 12 months, 18 months, and the trajectory of those symptoms, it starts with usually, we used to think concussion symptoms went away in the first 2 weeks. Well, we've come to find out that's not really true. We think the majority of concussion symptoms last for about the first month to 6 weeks, and then they start tapering off. But that 30%, around 30% of kids still have symptoms at 3 months, and that at a year out, up to maybe 10 to 15% may still have symptoms. And so you can imagine that this definitely changes how they are, living their life, uh, and whether or not they've been able to establish some back to baseline normative activities, and whether or not they're still able to learn and play the way they would prior to a concussion. We know that the post-concussive symptoms are dependent on a lot of interactions, so those can be somatic, psychological, or social factors. We also know that we don't really have great classification around these. I mean, we now have these 5 subtypes based on the CDC guidelines, but there's so many different ways that people can be evaluated for concussion and for symptoms. And there's some discrete measures that we're starting to use more as a community, but they still vary. We know that there's limitations to therapies, and those for children who have ongoing concussion symptoms, that we're starting to employ cognitive and behavioral therapy or some forms of psychotherapy to help them, but that may not give them full control of their balance back. If you've had a vestibular injury, meaning that inner ear connection with the brain injury, you may need some real active occupational therapy to help your balance, as well as physical therapy to help you with balance. If you've had ocular motor type of symptoms, you may need occupational therapy to help you figure out how to focus and to transition your ability to look around the room. And that all takes practice. It takes therapy, and we don't really know about how much therapy you should be getting. Is 8 weeks enough? Is 10 weeks enough? And many healthcare systems don't necessarily reimburse for extended therapies. We know that programs through healthcare organizations and private entities look different. So you may be able to out-of-pocket pay for concussion therapies. Your health system may actually have a concussion clinic, and the child may benefit from that clinic, but many health systems don't have concussion clinics. And then we're still limited by, what we know for children and youth, and that on average, services for children and youth are not on par with what we see for adults. And that's true for all traumatic brain injuries for children, not just concussion. There's research now in imaging, right? So are there novel imaging mechanisms that we can use to better understand what's happening in the brain? Could we actually see a visual picture of what's happening in the brain and after a concussion, and could we use that to guide therapy? Well, there's limited use in patients with the trauma, particularly in concussion, and we have a long way to go. These tests are very expensive and have yet to show that they will provide us with the right pacing of therapies in our patients. There are things called biomarkers, and I'm sure you've heard a lot about these. And these are typically tests that we take from your blood or saliva or spinal fluid if you have a very severe brain injury that are trying to measure the cellular changes within the brain to tell us whether or not, there's ongoing brain injury. We've had some progress with this, and that is that, there's been some clearance by the FDA for a blood test to look, or a couple of blood tests to look at changes in the brain after a head injury. Now you have to have access to blood. It has to be within the first 12 hours. And it's not really in time for diagnosis or management for children with concussion and youth. By and large, children do not want to give you a blood sample. By and large, you're not going to have somebody standing on the sidelines of a sport being able to collect that blood sample or get that child into an evaluation quick enough. But there is research that's looking at this, and I think that we need to be open to the idea that we may, in time, be able to better identify unique cellular changes in the brain that will help guide our diagnosis and management and therapies. And then there are genetics, and we know that there are certain genes that have been associated with risk factors for individuals who've experienced traumatic brain injury. We know there's a lot of work around the apolipoprotein 4 gene, which has been associated with Alzheimer's. There's been some links to dementia. And of course, we're always worried about individuals who've experienced a concussion or other brain injury, that they too are at higher risk for dementia, Alzheimer's, or what we've heard a lot about in the literature, CTE, or chronic encephalopathy, as a result of a trauma. But we know that in concussion, particularly in the fields of sports, because these tend to be the most captive audiences to conducting research, are collegiate athletes, so those that are in college sports, as well as, of course, the NFL and other organized sports, that these tend to be where we get most of our information. But they're not from the kids on the school, just running around the playground. They're a different group of individuals, and they typically tend to be older. So oftentimes it's hard to understand how this then also translates to children. But there have been some work around, could you have some genes that protect you when you have a mild traumatic brain injury or concussion? And might there be genes that actually hurt you? But really, all of the studies are very small, and so we don't really have good data yet to say we know more than what we're finding in these small studies. And then sensors, and you've probably heard a lot about this in hockey and in football and other sports where they're now required to wear helmets. We can have sensors in our helmets. We can have sensors also within our mouth guards. But the challenges have been, in the back of this hockey helmet, there's actually like a sensor bar that goes, kind of red, yellow, green, or it can just go red, meaning that there's been enough force to that helmet that would give you a high likelihood of suspicion that you've had an impact to the head that could be concussive in nature. But we know that there's no good measurement yet of force and angular acceleration exposure to diagnose a concussion. We just know that the helmet or the mouth guard is getting force. We know that it takes variable amount of force in every individual. It could be different. What might be a light hit to me and give me concussion symptoms might not disturb the next individual. And then current measures are just poor predictor of sports-related concussions. But it's a field that is heavily invested in, and many people who are looking to try to better understand that. There's even body armor where they're wearing it within their pads to try to figure out whether or not there's enough force coming into contact with the individual that may put them at risk for concussion. And this slide is super busy, but it's the only one where I could actually find a real study that looked at other kind of pharmacologic treatments. So other than treating for headache, we really don't have a lot. And what this study looked at is omega-3, so fish oil. And might there be a role for fish oil in individuals who've sustained a head trauma? And they looked at American football players. And they think that there may be some protective effect of taking omega-3s, but the jury is still out. And what dose and how much and how soon do you need to take it is still very unclear. So in summary, and I just want to make sure I'm not behind time. Nope. In summary, concussion is a silent epidemic for children and youth. There are high rates of concussion. They're happening often without evaluation and without recognition. And so, we have a whole group of kids and youth that may lack services to help them recover. We know that symptoms are very variable. We know that right now that there are some pre-existing conditions. There may be more, we just haven't identified. We know there are biologic conditions, but also that there are biological responses that are different in individuals and lead to their symptoms. And then also that there are now at least 5 subtypes that have been recognized. We know treatments, of course, are around the post-concussive symptoms, the subtypes, targeting getting children back into school to learn and play so that we maximize their quality of life. But we need to do that in a way that we know we're not creating any further harm to the brain. We know research is still in its infancy and that we have really a limited understanding of concussion's lifelong impacts. And with that, I'm going to close. I'm going to thank you for your attention. And I'm going to open it to questions. I will let you know that I have a number of free resources, both links and then also references for you at the end of this slide presentation. So thank you.
Excellent. Thank you so much, Karen. It was definitely filled with great information, and I felt like it really captured what's going on in North Carolina, what a concussion is, how it really looks, with children, even as opposed to, what makes it different from adults that might have, concussion or something like that. So if you have any questions, please enter the questions box now. We're getting a lot of thank yous, very good information, a lot of appreciation. We appreciate you guys for joining. One question is, where do you see kind of the gaps related to services provided for individuals that might have had a concussion? How can we really improve health outcomes based on your experience in a lot of different areas in the concussion field and brain injury field?
Yeah, I'd like to say that, I'm very cognizant of the fact that there are a number of gaps, of course, for adults as well. But for children and youth, I think that, we have identified that understanding of concussion is still, I wouldn't say everyone understands what a concussion is. I think we've gotten much more understanding, or there's been more understanding because of what we're hearing from the NFL and hearing from some of our collegiate sports athletes. And I think that that has given some, public awareness. But I think that the majority of families perhaps are not as familiar with when could a concussion happen that isn't necessarily related to a sport, and what symptoms would we be looking for when, you know, when these symptoms occur, should we be seeking immediate medical attention or seeing a healthcare provider? Should we even just acknowledge that something's happened with the school personnel so that they can then get a child into a concussion evaluation? I think the other big problem that we have is the relationship between healthcare and education. And oftentimes a child may be seen by a healthcare provider, but there's never a communication back to the school. And so that's a huge missing link. That kind of collaborative environment that we need to help children be successful really, really is it's kind of like looking at, it does take a village to raise a child or a youth. We need both the healthcare provider, the family, the extended community, the education community to really work together to maximize output for these kids, and also services. Um, Many of these services, children don't qualify for educational accommodations because their symptoms may be vague, or because they are able to return to learn in certain facets. But at what point can we better communicate these these evaluations? So what I'm seeing at time one when I'm evaluating a child after having a concussion to the next evaluation, how am I communicating those, advantages of that evaluation to the school? And how does that then help the school personnel advance the child or hold the child back if they're not making progress? And how do I, as a healthcare provider, better understand where the child is having difficulty in the school system so that I might be able to um, initiate services from a healthcare perspective? And I think that gap is really quite substantial.
Yeah, that is definitely something that I think is going to be interesting, to see where service providers and where we can find those different kinds of connections and more communication rather than the different siloed systems.
Right.
We definitely have some agreements with the gaps and how a lot of things that you mentioned are true for children having chronic illness issues or any sort of I imagine for behavioral challenges as well. So definitely a lot of gaps there. I wonder, so since you are the head of the Child and Youth Committee, I wonder if you could tell us kind of what that committee looks like. What activities do you guys have going on? What major areas are you looking at for prevention and awareness as it comes to the upcoming year?
Yeah, thank you. So it's really an honor to be the chair. And, I have a colleague who's co-chairing with me, Dr. Pete Duquette from UNC, who's a neuropsychologist. But we have wonderful membership. Our former chair, who is actually going to be providing the second part of the concussion web series in April. Lynn Maker is a school psychologist, and we have school nurses on our committee like Liz Newland, so we have representation from school nursing. We also have individuals from the emergency department. We have physicians in the emergency department. We also have an attorney who is actually a board member, Thomas Henson, who is a board member of the Brain Injury Council. We have individuals from the Department of Health and Human Services, Public Health, Department of Education. We have individuals who are in other professional walks that have an interest in children, who, particularly children and youth, around the topic of brain injury. Our focus has been to improve dissemination. So we have right now a brief that's been drafted that is waiting for some response by by the Secretary of Health and Human Services around improving the gap of communication uh, between healthcare systems and schools. So that is one initiative that we're working hard to try to bridge that gap. We've also developed databases to inform beyond the organized sports within the school system, but looking at recreational sports across the state of North Carolina. And how do we get information to coaches and individuals who are participating in sports so that they have a higher level of awareness around concussion, and then also some of the resources that are available to them. We are also working to better understand whether there are other brain injury um, occurrences, such as individuals who are poorly restrained in motor vehicles, particularly children when they get into that booster seat age group. Are they sitting in the booster seat? Is it preventing them from being at risk for a head injury when they're in a motor vehicle collision? Or are there communications that need to be improved around that with North Carolina's um, uh, highway safety? So we have a number of initiatives that are going on right now. We're really pleased to be part of the webinar series because it's allowing us to even more broadly, introduce the whole framework around concussion and what we're starting to get better at in identifying concussion and where we still need to do a lot of work, such as resources and therapies and having individuals work together to really come up with plans that are workable for families and children, because some plans are just not realistic, and some plans just don't exist because of where the child is. I mean, we really are quite fortunate that we sit in Raleigh-Durham, where we have three major medical centers that care for children with very large school systems with resources. But there are many counties across North Carolina that don't have that same access to resources. And we're trying to be very cognizant about how do we provide both schools and healthcare systems and providers with that type of information.
Excellent. Definitely sounds like there's a lot of good work that you guys are doing, throughout the state, looking out for children and youth. So definitely glad to have dedicated people like you on the, Brain Injury Advisory Council and on our team. I have, I guess, a minor follow-up question, and one of the comments in the questions kind of sparked it. They mentioned they agreed with you how the gap between schools, healthcare teams, and families are very very stark, very minimal, and that families don't know often where to go to or who to speak to about these gaps. Do you have any comments on, we have a majority of professionals on, how can we get that information in the hands of all the parents out there? What does that kind of increase in awareness look like when it can be difficult if they're already getting so many things in the mail, from the school, just like a blanket letter or, something that they have to sign for their kid to be able to go to school. Not that we're looking too much into the school system, because we're going to talk about that in another webinar, but do you have any suggestions for, the role that families can provide when it comes to concussion awareness, and how we as professionals can kind of bridge that gap?
Yeah, I wish I had the answer, and I wish I could give it to you in a nutshell, but I will tell you I don't have all the answers, and I certainly think this is one of the more complex scenarios that we have, and it's much like anything. How do we better inform individuals when there are health risks, right? And how do we help them understand the importance of taking a minute to kind of explore that information? Um, I would say to you that, one of the challenges we've had when we, created the second edition of the brochure was how do we get it to everyone? Which is why I provided you now with the link and easy access. And I think if there were a way that, this kind of dissemination could happen if there was a way that we could, every parent who had, some kind of email, Instagram, Facebook, Twitter account could just get a link to say, hey, what do you know about concussions? Click in here. That would be beautiful, right? I would say to you that that would be ideal. I don't know that our committee really has a bandwidth, which is why our strategy is how do we make that happen? I think webinars like this are a prime example of, tell one and then they tell more. And sometimes it's such a subtle, information session that allows for this blossoming of information, what I would consider downstream, right? So, or upstream. And I would hope that the materials from this webinar, which are made available publicly, I would hope that all of you on the call on this webinar are able to take the information and share it with those that you work with, or your local school system, your PTA, your kids' recreational sports, their coaches, and sometimes, it's just another parent who's coaching a recreational team. Provide them with the information. I think one of the things that we recognize is there are many children who are in some type of a sport where the coach really doesn't have a full understanding around concussion. And, it would be nice if there was kind of a public mandate that if you're going to provide some oversight of children who are playing something recreationally, that there be, a minimum level of exposure to perhaps concussion and maybe some other injury-related webinars. But more importantly, I think it comes down to understanding the importance that concussion is a brain injury. And I think if we can just even make people aware that a concussion is not just invisible, that there's truly something happening at a deeper level, both within the brain and within the individual, that requires attention. I think that's the first step. So I don't know that I answered that question well, but that is really the best I've got.
Absolutely. No, I definitely, it's one of those things that I don't know if anyone truly knows the answer, but I think it does start the conversation of, how we can be, make an impact on families and therefore children. So I greatly appreciate it. And that does bring the point that this webinar has been recorded and it will be available on our website under education and training and webinars, available to view on demand. So that's something that can be further shared. I'll include the slides as well to that link. Most of all the handouts that Karen mentioned should be downloadable through the GoToWebinar software that you're using to view this webinar under handouts. I also included a COVID-19 fact sheet just with the times, but I also included the presentation in PDF format, as well as the concussion brochures and posters and information like that. I will see one thing that I've been seeing out of the Brain Injury Association of Virginia is actually doing a couple of different concussion signs and symptoms on their social media and their website. And they've been doing like these maybe like 10 to 15 second PSAs on concussion, the signs and symptoms and use from a first person perspective, kind of what it's like to have a concussion. So I encourage you guys to check those out. Maybe that's something that can also be shared with family members, just to kind of start the conversation as well. If there are no other questions, again, just getting a lot of thanks and appreciation. So, and we're about close to time. So I encourage you to sign up for the next webinar so that we can really dive deep into schools, implementation, and further our discussion on concussion with Lynn Makor. Other than that, Karen, thank you so much again for participating in the webinar. You have such a great deal of knowledge and resources, and just really appreciate you taking the time and, even working and everyone joining in from home, but also Karen from home. And, I hope that everyone stays safe out there, keeps on their physical distancing, while keeping your mental health and activity up as much as possible, and helping those with individuals with brain injuries in any way that you can. Any final remarks, Karen, that you have before we close out?
Just one final remark. If you go to the link where we the link for the brochures and posters, you can actually go in there, fill out a little quick survey, and we can actually get those posters and brochures as a hard copy form to you. So I wanted to remind you that you could also get these materials that you could put out at your schools, or you could put out at your rec sports, or take to your church group or any kind of gathering. And so they're available. If you go in, you'll see order some now, and they're free of charge. So we just wanted you to be aware of that. And again, thank you again for the invitation, the opportunity to share more about concussion. And I wish you all good health, stay healthy and well. And thank you again, Lauren, for the invitation.
Absolutely. Thank you all so much. I hope you have a wonderful day.